Welcome back to EASD TV. Now, the EastWest Forum has been a feature of EASD congresses for the past dozen years. And this year they had a fascinating subject to discuss, and it was care through the eyes of patients. And I've got with me the chair and two of the contributors to that symposium, so let me introduce them to you. So firstly I have Dinneen, who is an endocrinologist from Ireland, in Galway to be exact. I have Marleen Kunnemann from the Netherlands, who has been talking about shared decision making. That was your particular thing. Noriko Kodani, welcome all the way from Japan. And you were talking about stigma in particular, and we're missing Bastian Hauk, but Bastian Hauk is so well known to you. I know you'll know exactly what his stand is. So the EastWest Forum, just to explain what that is, it brings together views from, exactly as it says, East and West.
That's it. And it's been a joy for me personally to be involved in shaping it for a few years. And it has a legacy. In the early days, it was looking at the prevalence, the incidence of diabetes in Europe and in Japan. Then it sort of looked at approaches to science, for example, beta cell biology, and always, Vivian, through the lens of comparing and contrasting, approaches in Europe and in Japan. But now it is we today explored, as you described, care. The focus of today's symposium was what I would consider as a clinician to be really at the heart of the matter, that human-to-human interaction between the doctor or the healthcare professional and the person living with diabetes. And we shone a light on that to try to understand how we can learn from each other between the East and the West.
So Noriko, let me start with you. Now, you were talking about stigma, and we've had a lot about stigma during this Congress. Stigma particularly for type 2 diabetes, but also stigma for type 1. How is the situation in Japan with regard to stigma?
So the situation of stigma in Japan is, I believe it's very different from your country because of the cultural background. People are not good at speaking out what they have, or they won't ask for something when they think that they can manage themselves. Then self-stigma start to increase in themselves, and we really think that is what we have to take care of for each patient, each people with diabetes. Sometimes they don't recognize that they have self-stigma, but by talking through, we try to have them to live a life that they can think about taking care of glucose management as part of their life, like brushing their teeth. Then in that way, I think they can get a happier life. Social stigma is another thing that we physicians have to work on. We do not have a full discussion yet like the one we had today, and we're really working on to have all the physicians know about the social stigma that people are facing.
So there's a self-stigma, there's a social stigma, but what about government? How does society in general think of diabetes in Japan?
So we still have the word that diabetes is related to their lifestyle, how they eat. So we have to start from that point. And today I talked about the language that the healthcare professionals uses. These are not well known in Japan yet, so that we have to start.
Because obesity is not the problem, the major problem that it is in other countries in the West, is it?
That's true, but so there are less obesity people in Japan, but in Japan, even if you're not obese, if you eat too much, you easily get diabetes sometimes. I think the function of beta cell is different among different populations.
It's fascinating the differences across the world. Marleen, your particular interest is shared decision making. Does that that question of stigma come into your work as well?
Oh, that is an excellent question. I think the stigma that we are facing in shared decision making, or patients and clinicians collaborating and making decisions about care, is the roles that we assume people have, and that people don't want to be involved, or they cannot be involved because they don't have the information and they don't know what the right decision is. And the point that I was trying to make during the session was that there are actually two experts in that room. We have one medical expert, and then we have one expert on what the condition and the treatment actually means in the lives of the patient. So they need to work together in making decisions, and that's what shared decision making is all about.
And in Japan, is there still a deference to the doctor? In other words, shared decision making is much more difficult in cultures where there is a deference and the doctor is always right.
So the word you talked about, having two experts in the room, I really like that. It is true that sometimes doctor always teaches or instruct patient what to do, but we are beginning to realize that not just telling them or instructing them what to do is good, because they know what's going to happen when they eat or when something happens to them. So we are trying to understand what they want to say to us, what they want to teach us, how their glucose level changes when they eat something or when they use insulin.
So here we are 100 years on since the first patient was given insulin, and actually right from the very start, diabetes established itself as a condition in which there was self-management. And actually, it probably is the leading condition in terms of patient expertise. And it's not recognised everywhere. And it's not, we say that we have more of that culture in the West. Actually, we have pockets of that culture. There's a lot of really quite bad practice and not recognising the expertise that patients have.
I think that's right, Vivian. And I've been admiring Marleen's work for some time, and I really like some of the concepts that she describes around making care fit in the lives of the person, who lives, and their loved ones who live with diabetes.
Because everybody is an individual and has different ambitions.
But what I think what Marleen's work, and of course I'm a clinician, I don't live with diabetes, but I deal with it a lot in my professional life. And, care plans are made, to use Marleen's phrase, at the point of care delivery. But they have to be implemented at the point of life.
They have to be lived.
Yeah, and I think we need to be reminded of that. Those of us who don't live with diabetes need to be reminded that I can ask you to do all kinds of things, but if they're not practical, if they don't make sense, if they are a burden, they're just not going to happen.
Can you think of an example of something that people are asked to do which is really not practical for them?
Well, so one of the examples that I gave during the symposium was of a patient who came in and mentioned that his daughter was in an abusive relationship, moved back home, had a bunch of small children, and then the patient comes in, HbA1c is not under control. What is the priority here? Well, it's not to look at the numbers, it's to solve the problematic situation of that patient and to make a plan on how to do that, so how to address the medical backstory and the personal backstory of this patient. Because we may be focusing on these numbers, but they're not going to do anything about it because that's not their top priority at this point. And that's the point that Sean was also perhaps trying to make, is that whatever happens at the point of life in the patient's personal environment is largely invisible to those working in a clinic. So what is left undiscussed is also left unconsidered when designing care plans.
99% of the time of a person living with diabetes is spent in their own environment,
Absolutely.
not in the clinic. And do you find, Noriko, that if the self-stigma can be lifted, that actually people living with diabetes do better as a result?
Yes, there are data that I've shown today showing that people having self-stigma will have decreased self-esteem and self-management for diabetes care. So we do
Fascinating.
believe.
So
yes.
sort out the problem, the life problem,
Right, yes.
before you start sorting out the numbers. A final word from you. Anything that Bastian said that, I mean, everything that Bastian says is remarkable. But
remarkable. I mean, Bastian, has mobilised a community, an online community, not just online. There were many of them in attendance at the symposium, rallying and cheerleading. But it is a phenomenon. I think that, to give EASD credit, Bastian had a DDoC symposium at this Congress. So not just paying lip service to the movement that he has established, but actually bringing it into the mainstream. As you probably know, 7 years ago in Stockholm, they weren't able to enter the Congress. They had to meet in a coffee shop that they rented a room. It's a lovely, lovely story. It's an arc, of impact. And I think Bastian and the DDoC movement and just the diabetes online community in general has to be the way forward. And I think, kudos to EASD, but also the challenge to EASD is not to stop here, to build on it and to get that patient voice much more, heard in our congresses in the future.
There's lots of nodding here. Thank you all so much for being with us, and congratulations to the EastWest Forum, because I think it's a fantastic initiative of the ESDs. So that's it for now from this session, but we're coming to you in a little moment. Bye for now.